Module 3 of the Vocational Rehabilitation Foundation modules, and today we're going to focus on key concepts of vocational rehabilitation. So our session aims, we want to review key concepts of VR, including goal setting, the biopsychosocial approach using the model, legislation underpinning return to work, disclosure, measuring outcomes, and some considerations and change for future planning. So in terms of goal setting, we've already discussed through the other modules about how early discussions can really help with realistic goal setting. It can help with supporting our patients to manage their expectations. It might be that, dependent on whether they're keen to return to work quite soon or they don't think they can return to work, it's just helping them understand what support is available for them and what to expect after their stroke. So those early discussions are really important. Understanding the job demands as well helps us set some more kind of specific goals and helps us inform our intervention plans. From doing job demands, we can kind of analyse the activities that they need to do at work and kind of see where those gaps lie in terms of impairment after stroke. Some patients are quite fixated, so it's using this to channel that energy into kind of creative goal setting. So it might be that work's a long way off, but if you start using some of those meaningful occupations in goals, we'll come on to a case study in the next module about how we can do that. And just touched on that there, kind of links quite nicely into using those meaningful activities in goal setting. Thinking about every contact counting, I think it's important to consider all members of the MDT, not just kind of people who are doing the therapy or people who are providing the medical and nursing support. It's thinking about those staff that are on the ground, front facing the patients all the time, like the clinical support workers and cleaning staff, all of those, porters even. They might have conversations with patients all the time about different things with regards to work, and that might have an impact on how much they disclose if they've got a really good rapport. Thinking about active participation, that goes without saying with every goal really in rehab post-stroke. If the patients are more active in their goal setting process, then they're more likely to achieve. And providing that education around what's realistic, what can they expect down the line, and it's both patients and families. If we have a think then, what the barriers are to return to work. So we did this as a team Slido discussion. So even if you just want to pause your video for a minute and just have a bit of a thought about what could prevent people from returning to work, factors that might influence people returning too soon, issues that may cause barriers once back in work, that should say not on work, back in work. Just have a minute to think about that, and then I'll share some of the results that we had from the group last week. Oh, and also problems with sustainability and success. Sorry, missed that bit off. So this is what actually we came up with. And I think just looking there, there's a lot to cover. So I'm sure you'll be able to pick out the ones that are in colour or the ones that are said more often. So fatigue was said multiple times. Anxiety, low mood, so those psychological side of things, fear, environmental issues. And then there's the more kind of issues with sick pay and poor relationship with co-workers and colleagues. And then I just came up with my own kind of list as well. So thinking about physical limitations, so that post-stroke impairments and fatigue, upper limb, lower limb, balance issues, could even be kind of down to vision. Cognitive impairment, changes to ability to learn, attention processing, less able to manage demanding cognitive tasks like multitasking. And also I recognised when I did the presentation last week that I hadn't put a separate section for communication, but obviously communication is a huge barrier with return to work. Those psychological barriers, so reduced confidence, mood, anxiety, fear of relapse, getting worse. Driving, so either having to drive for work, so maybe they are bus or taxi drivers or HGV drivers, or their post men or women. You know, it's those issues with actually being able to do the job safely if they're not able to drive, or getting to and from work, so it's commuting issues. And then trying to seek other ways of getting to work might be using public transport, which, you know, increases fatigue, or being able to pay for a taxi, you know, that's not always financially available for people. So that can exacerbate those symptoms of worry, fatigue, etc. The lack of access to VR as well. Even not necessarily the specialist service, but if there's gaps in knowledge, it's helping that sustainability and that smooth transition back to work, and being a resource for the individual and also for the employer, kind of sharing that resource. And with a more established VR pathway, those professionals are able to see somebody for longer to support that sustainability. It might be that they're seeing them for a few months into their return to work, and progressing their reasonable adjustments as they improve or as they face maybe new barriers. Financial pressure is a big one, so it's maybe loss of income, might make them go back too soon, or issues with sick pay entitlement. Some people might not be able to access sick pay, or they might not get it for very long, or if they're self-employed, main kind of earner in the family, you know, they might have dependents, people that they care for that depend on that money coming in. Skill gap and change in roles, so it might be new procedures in the company or the employer, and then difficulty managing their previous role. Social pressures are a big one, maybe that's from family or their own kind of social kind of expectations of themselves, their status and their identity as well. That's a huge element. Unclear expectations, that might make it less sustainable or successful if they have what they're expecting for themselves, maybe the employer isn't expecting, and that can cause some disparity. Organisational barriers, so that might be those ones that we say about lack of support from employer, the stigma, maybe inflexible working conditions, and then those legal and administrative things kind of linking in with that sick pay policy, managing adjustments, and then more discrimination and disciplinary and legal issues perhaps. So this brings us on quite nicely into a biopsychosocial model for rehabilitation, and it kind of links really nicely with vocational rehabilitation. So it's looking at people's health and well-being, and it's not just their medical condition or what health needs they have. And it's thinking about those social, psychological factors that play a part in and somebody's ability to manage their condition themselves. And we've already said, you know, quite a lot about them being motivated to manage, and that then in turn drives their return to work or drives their goals and their kind of motivation to achieve those goals. So this model, if you're not familiar, highlights the relationship between the biological, the psychological and the socio-environmental factors in rehab. So, you know, I'm sure we're all familiar that behaviours, thoughts and feelings can influence a physical state. I'm sure we've all come across patients who have got elements of fear, anxiety and worry that can exacerbate those physical symptoms or exacerbate those stroke symptoms. And it's working out those kind of flags, which we'll come on to in a minute, and how we can support that. So, in terms of our biopsychosocial flags, this was a concept that was introduced, you know, nearly 30 years ago, originally applied to MSK conditions. So you'll all be familiar, I'm sure, with red flags and the flag system with serious comorbidity and serious pathology, often linked with, you know, if you've got someone who's got like a chronic back pain and they've got those red flags, that sort of thing. So it looks at aspects of the person, their problem and the context socially. And it looks at how those factors play a recovery. And I think what's really key to note on this is it isn't a label or a diagnosis, it's just factors that influence ability to manage goals or achieve goals and ability to kind of their recovery process. So these are the flags here. So actually, when you look at how they're categorised, all of those barriers that we've just considered together can all be categorised into a different colour flag. So I've just already mentioned about the red being serious pathology. For sometimes in stroke care, it might be failure of treatment. Those orange flags are our what we call our psychiatric or our mental health difficulties, such as depression, bipolar. Those things could be previous and pre-existing to the stroke, or it might be that they've had a new diagnosis of those conditions, and it's just how those play a part in managing. Our yellow flags are our belief systems and how we judge ourselves. So that can be our emotions, maybe that we've not got some great coping mechanisms or techniques. Might be that we're not, patients aren't willing to engage in rehab. They might be in denial of their symptoms. Motivation might be fluctuating. They might have, sick role type behaviours or have secondary gain, loss of benefits if they do certain things. They might be quite passive. They might be expecting those people in our rehab teams and our MDT to be doing it for them. So yeah, that, I'm sure you can all identify with those. The blue flags are our kind of organisational relationship between occupation and health. So that might be poor support from employers, low job satisfaction previously, stressful nature of work, thinking that going back to work will cause a re-injury. So they're quite common. And then finally, well, not finally, but black flags is our systems, policy, context, so legal things, the Equality Act, actual services in healthcare. So it might be, unhelpful company policies or the company not being aware of reasonable adjustments, legal action. Hopefully not, but you never know. Social isolation in the workplace, it might be that stigma and then not having that kind of ability to engage with their work colleagues as much, and threat to finances as well. But then with all of those flags, we must also consider our what we like to call the pink flags, and that's our protective factors. So it could be that they engage well with rehabilitation, or they've got really good job satisfaction, they've got a great relationship with their colleagues, their employer's really able to adjust and is quite accommodating. They might have great family support, friends, they're clear about their goals, they've got a really good drive in rehab, and they self-manage, they're really passionate about work, and it's a real driving factor for them. So sometimes they may have some of those other flags, but if they've got these pink ones running through, it's really, really helpful. So if we just think a little bit about legislation, I'm not going to go on too much about this, but I think it's important to know what the legal background is with return to work. So our key legislation would be the Equality Act. And I've already mentioned this a little bit around reasonable adjustments, but so there's quite a significant definition. So it legally protects individuals from discrimination based on their disability, and it's a physical or mental impairment that has substantial and long-term negative effect on your ability to complete daily activities. So it imposes a duty on employers basically to make reasonable adjustments. So that's it in the long and short of it. So they're the kind of words that are used in the legal act. So physical, mental, substantial, and long term. So when it comes to substantial, it's thinking about the person may experience kind of difficulty with use of their limbs, walking, vision, communication, cognitive processes, like things like memory, concentration, balance, that sort of thing. And long term is the effect of the stroke have lasted or is likely to last at least 12 months or for the rest of the person's life. And I think it can be quite difficult at the beginning when we're thinking about return to work, because often, 9 times out of 10, they aren't 12 months down the line, they're in their early supported phase. They're leaving hospital and it's sometimes not even been, a month, 2 months. Obviously we know that people can be at all stages in their rehab when they leave hospital. So with something like a stroke, with phased return to work, those when it's not a permanent or potentially not a permanent change, those adjustments are, it would be good for employers to be able to do that for patients and individuals. Just going on to a little bit about discrimination. It's direct and indirect discrimination because of somebody's disability, and it's not being able to make those reasonable adjustments. And it's not about making everybody the same, it's about making it equitable so that you adjust so people have the same opportunity as others. Harassment and victimisation are two things that would kind of categorise discrimination. So there are other legislations that are out there that are kind of govern the return to work or are important to consider, I guess. This isn't, we wouldn't expect people to be, really, really key in understanding these acts, but it's just knowing that there are legal frameworks out there to support you, the individual, and the employers as well. So Health and Safety at Work Act is to ensure that everybody is protected in terms of health and safety. It might be that you are kind of in breach of these legal acts if you don't work to the same level as you did before. It might be that you would need to drive a forklift truck and you're not able to drive under the DVLA, but forklift trucks aren't governed by the DVLA. It's normally a private company policy and training. So obviously that would be putting yourself and your colleagues at risk. Employment Rights Act, looking at fair procedures before dismissal. And that's on the kind of the grounds of sickness absence. So it's being able to have that framework there to support them. Human rights, obviously we know that covers a huge amount, but working rights are one aspect of the Human Rights Act. Data protection, so that's kind of around specific medical information that's deemed sensitive. And we need to make sure that the statutory conditions are met to process that data, especially if patients are having to disclose information about their health needs. And then the Employment Act just helps with statutory rights for dismissal, disciplinary and grievance procedures. So if we go on to disclosure, this is often, so when we've been doing our consultations with the stroke networks individuals, this has been one of the biggest factors that we discuss. Disclosing information about a condition can be very overwhelming for some of our patients, especially if they're struggling to accept what's happening. And each patient will have individual circumstances and concerns that will rise from it, and that can impact on the complexity of your cases. So what we would say normally is to be encourage people to maintain communication with the employer. What's really key to note is that you're not obliged and you have no legal duty as an individual to share your condition under the Equality Act, and healthcare professionals are not obliged to share with employers. So it's actually down to the patient who consents to what is disclosed. The healthcare professionals can be there to support that, but they're not the ones to disclose that information. It's the individual themselves. We've already said, that you could be in breach of contract if you don't disclose certain things that you need. It might be a condition of employment. Mentioning your health condition can give you access to reasonable adjustments. Because we've said, haven't we, under the Equality Act, that it would be discrimination if you did not have access to reasonable adjustments. And there's the government grant system called Access to Work, which your patients can refer themselves to, which you can support. It's an online process, but that will help with being able to manage those reasonable adjustments. It might be that they need a grant towards adaptive computer or desk or seating. Or they're also able to provide subsidised taxi accounts. So if somebody isn't able to drive, there is quite a long waiting list for Access to Work. So if you're considering it for your patients, I would encourage them to do it sooner rather than later. We've already kind of mentioned about the Health and Safety at Work Act. So it's disclosing that information that's Kind of a good example was the forklift truck driving, to make sure that they're safe. Education and information that's relevant to the condition. So that's a nice one to support employers, I guess. So so that they kind of understand what the difficulties are for the person, and how that might impact on their condition. And if that education is provided, it normally helps kind of bust those myths a little bit about, especially with fatigue and cognitive difficulties, the silent kind of invisible impairments after stroke. They could be really hard to describe, and often it might be where you as a professional can help your patient with that. I did send out some leaflets last week about information for employers post-stroke, which can be really useful. We just said kind of supporting a patient to be in control of what they disclose and what they consent to disclosing. And then the Scope website is really nice. I've put the link there. It's got loads of information about disclosing disability to an employer. Obviously, it's not necessarily stroke specific, but it kind of goes through all the processes from applying for a job, interviews, reasonable adjustments, kind of pros and cons of disclosing, how much to disclose. So that's a really nice resource, even if just for you to have a bit more further reading about it and have it in your kind of back pocket for a resource. So just wanted to talk a little bit about outcome measures, really. So we already know that we complete our SNAP audit, and work status is on there. So we have to look at this when they've been discharged from, or at the end of their stroke journey, and it's usually reviewed again as well in 6-month clinic. So it's whether they're in full or part-time work, and then thinking about what their type of work is: employed, self-employed, volunteering, retired, and whether they're in training or studying. And then I think I was saying on the training last week that I'm not completely up to date with the new SNAP data set, just because I've been out of the stroke kind of clinical world for 6 months. But I believe that there's an element to one of the sections where you need to complete minutes. I think vocational rehab is a new element to categorise minutes in, sort of recognising that we are doing it and how much we are doing. And then we also just need to consider other outcome measures potentially if you're thinking about this in your service. SNAP isn't necessarily the most sensitive. It doesn't look at kind of contractual hours that they worked before and then, or that they're kind of contracted for, or how many hours they actually work now. Thinking about other measures, so like fatigue, well-being, might be looking at kind of actual physical measures as well, for upper limb, etc. And then there's some specific outcome measures. So there's work-related self-efficacy scale, work and social adjustment, and work productivity and impairment scale. They're both all a bit of a mouthful. So you can look those up and they are free to download as well. So just kind of coming to the end of this part of the training, I just wanted to kind of look at what considerations could be and what change potentially there'd be in the future, and things that you might want to make in terms of your pathways for delivering elements of VR, whether that's at the hyperacute stage all the way through to outpatient setting. So obviously we've already spoken a lot about the stroke guidelines, and I think can we be doing something local to help with service development, even if it's a screening tool or a new outcome measure to add in, or another kind of layer in your initial assessment to talk about work and hand that over to the rehab teams. We do need more detail for nature of intervention and duration of VR, and that's across the board really. Obviously we've said about it being a government hot topic, and I think it recognises the NHS and health professionals as a key VR provider. I think we need to promote our role really and the importance of VOC rehab, whether that's small tweaks to current pathways or big projects like what Ray and I are working on this year. I want to promote the strategy across the stroke rehab journey. So I think I've been trying to do that on here, is trying to help you see that it's not just for once people are at home. We need to level up training skills and access to core professions as well, and continually promote the importance of the MDT in stroke rehab. This is one of our big ones from our outcomes for this project, is thinking about a formal education route. We've got to consider what that might look like. Do we need to ensure that our community of practice at that intermediate level continues? Do we need to develop a formal training route? Could it be something like a master's or a module in master's? Do we continue those consultations that we're providing? I'm currently working on a project with the Royal College of OT around VR outcome measures. There's so many out there, it's sometimes difficult to know which ones to use. And developing an outcome measure from its entirety is extremely difficult. So we've kind of come up with a toolkit to kind of almost have a home and a directory for all of the different outcome measures that professionals across the VR world, not just stroke, have used in the past. And we want to kind of promote gathering more regular in-depth outcome measures, outcomes to support business planning in the future. There's that collaboration, not just between NHS and employment services, but between kind of the stakeholders, the policymakers, those higher level kind of commissioning boards, to support the journey really for VR. And then I did just do a scale at the end, and this is what people felt as though their main learning from today. So even if you just have a little jot down what you think, and there I think early discussions again, the websites, useful resources. So yeah, and then just some references there for some of the information that I've used, and the biopsychosocial model is up there and the flags as well. And so if you do have any further questions, you can send me an email if you think of anything individually or something as a service that you want support with. I'm always willing to come in, or a Teams call, whatever you might find useful. Thank you very much.